Well, hello, and thank you, everyone, for joining us on the East Coast. It's in the late in the hour. For those who are joining from the East Coast, thank you for taking the time to join our first Amplify Surgical webinar on the topic of small portal access lateral system. So we're very excited about that. With that, if we can start sharing the screen. I will go ahead and introduce our faculty for this webinar. Great. So today we are joined by our lead proctor, Dr. Stefan Renaud, who is based out of the area near Charlotte, North Carolina. And then after his presentation will be followed by Dr. Tyler Carson, who's a neurosurgeon up in northern part of Los Angeles, Palmdale, California. And then the last presentation will be led by Dr. Namath Hussain, who is a professor and a neurosurgeon at the Loma University Medical Center here in Riverside, California. So with that, I am very excited to introduce our first speaker, Dr. Renaud, and he'll take us away. Thank you very much.
All right. Thanks, Andy. I'd like to thank Andy Choi and the rest of the Amplify team for organizing this talk, and then also just all their hard work in development of these products and kind of growing this company, which has really made some strides over the last 5+ years since its inception. So thank you for having us, and thank you for inviting myself as well as our other two faculty, Dr. Carson Hussain. All right, why don't we go to the next slide? This is just a slide with some of my credentials on it. Nothing really that important. I would say also that I did some training on the West Coast where our other faculty are now in practice. So we probably have a similar interest and background and experience in doing kind of minimally invasive surgery. And as we'll get in this talk, I think you'll see that that really necessitates using interbodies for fusion. And that's what kind of drives the interest in this particular device. Why don't we go to the next slide? And I'll say that, my disclosure is I'm a paid consultant for this talk, and I have some investment in the Amplify Surgical company. So I thought it'd be interesting to focus a little bit on the historical context of lateral interbody fusions and kind of bring us up to modern day, and then particularly this product and why I think it's really the next step in evolving MIS lateral fusions. And then I think the other speakers are going to talk a lot more about kind of the specific surgical techniques. I'll go over a little bit of that with my last part of the talk, but really the first half here is going to be kind of setting the stage for this particular device and this company's kind of unique placement in the market. So, 2001 timeframe, roughly, Pimenta started putting out some papers here talking about this kind of modernization of the lateral approach to the spine. That was not, a big thoracotomy. It was more minimally invasive, didn't necessarily have an approach surgeon, and was using nerve monitoring to gain access in a safe manner. So even in the very beginning, one of the biggest things that they mentioned having problems with was particularly the L4-5 level, and having all these patients with kind of posterior thigh groin dysesthesia and objective weakness. And then a few years later, they had some more papers, also Pimenta and some other known doctors, kind of more study of it, continue to have similar problems and similar rates. So why don't we go to the next slide? So jumping forward now, like 10 years into this procedure being done in the US, much wider adoption, large centers like some of these surgeons here were at HSS. Published their papers, and in these papers, it wasn't like those early ones where they had 20 patients. I mean, these were pretty large studies, 919 treated levels, and presumably with some amount of experience, right? These surgeons had been doing it for somewhere between 5 to 8 years now. And even then, look at how high some of their immediate post-op complication rates were, somewhere in like the 40% range. And they showed good improvement. If you look at their 12-month follow-up, the symptoms had greatly improved, but there was still a 2.3 or 2.9% incidence of continued sensory and motor symptoms. And kind of interest, the bottom study had that BMP seemed to have a higher incidence of these symptoms. So I don't know if that's a separate discussion if people are still using that or not. I have not used BMP for probably 10 years now in my practice. Go ahead, next slide. So it brings up the question, well, why even bother with this lateral approach here that's got these complications that you don't see from, say, a posterior instrumented fusion only, or maybe even a typical TLIF or PLIF fusion. Well, I think this brings us back to the point about minimally invasive surgery. I think at this point, almost everyone will admit that it's been fairly clearly shown that MIS has some advantages over open spine surgery, right? Less blood loss, lower infection rates. So that should be fairly widely accepted at this point. And I think if you believe that and you're trying to use that approach in your practice, then you have to be relying on the inner body more to do the work, right? You no longer have that big open area to lay bone graft and fuse the whole posterior spine. So you have to rely on the inner body as your fusion substrate. And you also are not going to be doing a complete facetectomy and laminectomy to kind of mobilize the spine. So you have to rely on the inner body to do your work of reduction of spondylolisthesis, of indirect decompression of both the central and foraminal regions. So looking at this image in the top, it just kind of reminds you where the hardest bone is if you're going to try to push on the spine and use indirect decompression techniques. And then if you look at the bottom picture on the right side, 80% of the spinal loads are through the front 2/3 column of the spine, and 90% of the articular surface is in the front 2/3 column of the spine. So, that's where the money is. And then this picture on the bottom left kind of still surprises me to this day that a lateral fusion cage covers the most surface area out of all of these possible fusion interbodies. Next slide. So if we're all in agreement that minimally invasive surgery is good, that lateral fusion is maybe the most attractive version of that for many different pathologies, then here we are, we're trying to do it, right? So if you jump forward over the next like 10, 12 years, there's been learning curve and we've gotten better at doing this approach. One of the things, I won't get into these studies too much, but that several studies have come out showing kind of retractor time and discectomy time has played a role in decreasing those post-op symptoms. So in general, the studies would suggest if you can stay around 30 minutes or less, some of them 40 minutes or less, that you tend to confer less neuropraxia. So that's one thing. The second kind of learning curve thing is the actual approach or the corridor by which you're getting to the disc. And we'll go into a couple studies with that. And then the last thing is retraction, which is like how big are you actually opening up the corridor to do your discectomy and put in the inner body. All right, why don't we go next slide? So, and if I think the next slide one more time. Yeah. So on the bottom left here, the old Morrow diagram of where all the neural elements are, how, something like 90% of them are in the posterior 30 to 50% of the psoas, at least above L5, drove people to say, well, why don't we start going more anterior? So we'll go either into what's called a, pre-psoas direct lateral approach, right? So we're still in a lateral trans-psoas corridor, but we're going to go in front of the psoas and pull it back, or going into a true anterior to psoas or oblique fashion, where you're actually standing on the abdominal side or ventral side of the patient, right, and working back. So those studies definitely showed some promise, and there's a whole bunch listed here that showed decreased neuropraxia postoperatively, but they still had some, and there was some increase in vascular complications for some of these patients. So I put up this picture in the top left to just kind of demonstrate, some of the difficulties with just going more anterior. So one is that you need a working corridor if you're going to do a true, anterior to psoas. And if you look in that picture in the top left, there's very little room between the vessels anteriorly and the psoas. So this is one where it's like, I don't know if you can access that, or you might have some second thoughts about accessing that. And then the second thing is this is just a patient with a very large psoas, and it's kind of anteriorly drawn, right? Which has been described as kind of this Mickey Mouse ears appearance. So even if you went in front of the psoas and tried to pull it back in order to eventually make an annulotomy and place the inner body somewhere in the middle of the disc space, think about how much mobilization of that psoas you have to do, right? So whether you're getting a neuropraxia or whether you're just getting, psoas muscle irritation post-op, you're almost guaranteed to get that. So this may be, whether you go trans-psoas and anterior direct lateral or oblique, all of them are going to be fraught with some potential complication. But maybe if you can have a smaller retractor be faster, that's of more interest, right? Next slide. And then here's another study that just came out in April about approach. And I thought this was kind of interesting because they were very selective. So this wasn't like a massive number of patients in the study, but it was very limited number of surgeons, only L4-5 level. And they looked at doing them traditional trans-psoas versus going in the anterior third and kind of splitting the muscle. So they called the traditional group X, the modified anterior 1/3 group A. And they were also, I thought, pretty critical of any post-operative neuropraxias. So any sensory changes greater than 3 weeks and any motor grade changes of 1 or more compared to the contralateral leg were considered positive. And I'll just say, like, in my practice, a lot of the patients have some discomfort, especially with like straight leg raising and hip flexion immediately post-op. So I think they were probably pretty strict on saying that people had some symptoms in this study. And I thought there were a couple of interesting findings that objectively, the nerve monitoring seemed to give much higher numbers when they went into the anterior third of the psoas compared to traditional trans-psoas. You see that 13 to 18 number. And then they also had quite a different complication rate between the traditional group at 10% and the anterior group at 0%. So I thought that was pretty interesting. Next slide. So, and then just to kind of throw a little curveball at you here, as I was preparing for this talk, I happened to come across this on my LinkedIn feed like yesterday. So I just threw it in here. I think this is a study that Uribe is presenting at ESMIS this year. And he talks about doing a study where they did kind of similar to the study we just talked about, where they had a traditional kind of trans-psoas approach imaged in the left, picture A, and they had kind of very low numbers on the EMG readings. And then they had a little bit more of an anterior approach where they had more muscle, and that did show significant increase in the EMG numbers. But they said that in their study, it showed no difference clinically in the neuropraxias post-op. And I think that the bottom pictures kind of show that if, regardless of where you go in the psoas, if you open up the retractor big enough to get to the same disc space, right, to do the disc prep and put the inner body, you're probably going to get a similar amount of either psoas irritation or neuropraxia. Next slide. So, to kind of summarize that, being fast is probably good, right? Less than 30 minutes or so. Modifying the approach to go anterior is probably good, but the studies seem to be somewhat inconclusive. And then again, if you're going to have to open the retractor to put an implant that's like 20 plus millimeters A to P, you're probably going to get this, some irritation there. So this kind of opens the talk to where we are now, which is having expandables that will open in an anterior to posterior direction so that you can put them in through a smaller access point might be kind of the next step to move the evolution of lateral fusion forward. Next slide. And there's a couple of studies that have come out in the last few years kind of looking at this a little bit more. So this one by Nunley in 2021, prospective multi-center trial, looked at 1 and 2 level fusions. classic trans-psoas approach, so not described as going anterior or anything like that, but they were strict about only using 18 millimeter ports. And I thought it was interesting on the right, you see a whole bunch of demographics on their patients, the number of levels they use and all this. But one thing I thought was interesting was that their mean retractor or portal time per level was about 30 minutes. So they're fairly facile surgeons with this technique. And then all these numbers below are just talking about low back and leg and VAS. So why don't we go to the next slide? And the top two slides are also just looking at overall kind of success of their surgery and reduction in back and leg symptoms. But the bottom chart here I thought was interesting. And what I took from this is that the green line is kind of back and leg symptoms in patients, particularly anterior thigh, pre-op and then over the year following. And the way I would differentiate this green and purple line is, I think if the patients had a lot of preoperative anterior thigh symptoms, meaning they may have had like an L3 or L4 radiculopathy, they're in that green line group, right? Where they improved with surgery, but it took some time for neural healing and so on. And at 12 months later, they're a lot better, but they're maybe not totally better. But if you take the purple line, I think that's the subset of patients that were less likely to have anterior thigh symptoms before surgery. And therefore, you're really probably talking more about surgery or approach-induced thigh symptoms, right? So that's probably the number the graph you want to look at. And it's interesting. One, they're immediately at the time of surgery and 2 weeks post-op, they're already better than the traditional 40% that we saw in studies from 2006 to like say 2017, right? So they're already better at around 20%. But then at like 6 weeks and on, they have basically 0% continued neuropraxia. So it seems in the study that using an 18 millimeter or small retractor seems to convey some improvement in the neuropraxia symptoms. Next slide. And then this was a similar study in 2021, also multi-center, 200 patients, 254 levels, so pretty good size. Also trans-psoas, also 18 millimeter ports. So very kind of similar. Their retractor times also 30 minutes. So they seem pretty good on as far as their learning curve and technique. Next slide. And I thought that this was a subset analysis they did, looking at only patients that had little to no pre-op anterior thigh pain. So they really kind of sussed out this group. And I thought that both the subjective and objective findings were pretty impressive. So again, their subjective neuropraxia symptoms were around 20%, so 18 of 91 patients, and 50% of those were resolved at 2 weeks. Another 44% resolved shortly thereafter. So they had 94.4 resolved 6 weeks. And then the remaining resolved at 3 months, right? So that's a lot better than the 40% up front with another 2 to 3% at 12 months traditionally. So it seems like maybe we're onto something with this retractor size. And similarly with the objective symptoms, they have very little objective weakness and they essentially all resolve by 6 weeks. Next slide. So in summary, less time seems to be good, right? Going more anterior in the psoas, maybe not. Some of the studies say it does help. Some of the studies say maybe it doesn't help. Maybe it just makes you feel better because the nerve monitoring looks better, but you're still maybe retracting the same. And then this last point about kind of retractor size, which is kind of agnostic. It doesn't matter what approach you use if you're not opening up the retractor as much. It seems that there's some evidence and it would reason that would put less both stretch on the psoas and actual neural pressure. So next slide. So voila, here we are. Brings us to today looking at this company and this particular implant. And I think this picture on the left, is 1,000 words. You're putting this implant in at 13 millimeters. probably one of the smaller cages on the market for lateral. But once it's fully expanded, and it expands first in an anterior to posterior, and then it expands in a vertical direction. And once it does that, you're looking at actually one of the, larger implants at 22 millimeters anterior to posterior. And they've got, a myriad of different lordotic options and, widths from left to right, like most of these cages. They come 0, 7, 12 degrees, and I think even some 18-degree sizes. So there's options to fit, all sorts of different anatomies. Next slide. All right, so I just have one case to kind of go over. This is a 66-year-old lady with degenerative kyphoscoliosis. She had a lumbar lordosis pelvic incidence mismatch at 34 degrees. She had a couple of lateral spondylolisthesis, mostly at 3, 4, 4, 5, and moderate to severe foraminal greater than central stenosis, kind of chronic symptoms, had failed all sorts of treatments, oral meds, PT, etc., and it had a positive EMG. Next slide. So here's kind of her pre-op standing x-rays on the left. So you can see, kind of mid-lumbar, degenerative, curve, listhesis, significant interpedicular collapse on the left at, on the right, sorry, at 4-5, and on the left side, kind of L2 to L4. Now our lateral image there, you can see that, she's just got kind of that flat back picture from all the DDD. Sagittal MRI picture in the middle. You can see kind of L2, 3 with modic end plate changes, and the kind of predominance of her degenerative disc pathology from L2 to L5. L5S1 appears pretty well hydrated, above L2, pretty well hydrated. And then here are some axial cuts going at the L2, 3 level at the top, followed by L3, 4, followed by L4, 5. Okay. I'll go to the next slide. So one thing I'd say that's great about this particular implant is that you don't have to change that much. If you're somebody who does lateral fusion already, just do what you're doing. You're just using this implant that's better, that might allow you to access in a more minimally invasive fashion. Okay, next slide. Meaning we're not trying to teach you something totally different about the technique or how you're doing things. It's really easy to adopt this technology into your practice. So here are some intraoperative films here, just marking on the skin, over each disc level, and then, opening the incision. I personally have done all sorts of different approaches. Again, I've done trans-psoas when I first trained and came out in practice. I've done anterior, so going on the abdominal side of the patient. And my kind of default technique now, what's fastest for me and seems to be most reliable, is to be doing a direct lateral, but going anterior to the psoas. So I try to go in front of the psoas and kind of pull it back. So that's what I'm doing here. And you can see that the first dilator with the wire is kind of going from a little bit of an anterior to posterior direction. And then in this case, we kind of mixed it up. I did one level through a tubular system. Most of the time, though, for me, I use a 3-blade retractor system, and I just try to open it very minimally. So, and I'll show you some pictures kind of comparing the two. Next slide. So I will say there are a few unique or proprietary instruments that help you do some of the disc prep through these minimal access channels. So on the left, there's a picture of a cob that you can put in, and then you dial up the handle, and you can see that the cob from the left picture to the middle picture kind of opens up. And Andy will have to correct me if I'm wrong, but I think it goes in at something like 17 or 18 millimeters, and when you open it all the way, it's like 22 millimeters. So for me, when I get down there, I make an annulotomy normally with the knife, and then I kind of cob down each of the end plates. I don't release the contralateral annulus right away. I try to get out as much disc as I can. I use some rasping trials. I use generally 3 rasping trials to kind of prep the disc, get the rest of the disc material out. Once I'm confident that I've gotten all the disc material out, then I'll go release the contralateral annulus, and then I'm really using my dilators and sizers to get the appropriate implant. And this picture on the right is a picture of another proprietary instrument that they have here, which is a kind of sizer and dilator at the same time. So this thing goes in also kind of collapsed and small in a anterior to posterior size. It goes in, I think it's 11 or 12 millimeters, and then it opens up to 22 millimeters anterior to posterior. And then it's got markings on it very similar to any other trial sizer, and it comes in various heights, so that's kind of nice. Again, it allows you to go in through a very small access. Once you're in the disc space, you can kind of open it up, and then you can kind of mallet it through to make sure that you've kind of cleared the channel for your inner body. Okay, next slide. And here's just some pictures showing the 3-blade retractor approach. And you can see on the left that maybe in the bottom left corner of the retractor, you can see a little bit of space. I might open it like 1 or 2 clicks anteriorly, and maybe no clicks or 1 click kind of cranial caudal. So, and then here's an intra-op picture of that, looking down the retractor with the implant in there. So next slide. And here are some pictures, more intra-op pictures, but here's a picture of like the 3-blade retractor next to a 20 millimeter metrics tube. And here's a picture showing some measurement on the side. So just so you get an idea of, it's not quite 18 millimeters, but it's like 20 millimeters, So, and I think, most of the time when I'm opening it anterior, it's really just helping me to kind of push the posterior blade back to kind of keep the psoas back. That's most of the reason I'm doing it. I'm not really doing it to gain exposure per se. And this picture on the left is again a intra-op picture from that earlier case that we started with. Next slide. And here are a few more intra-op pictures, again going back to the first level from that case through the tube, showing a sizer. And then here's the actual inner body going in. And on the bottom right, I think this is a great picture to just kind of show you how much, expansion you're getting from anterior to posterior with this cage and how small your access point can be. Next slide. So here are kind of a summary photos of this case. On the top left is the pre-op films. On the bottom left is the intra-op inner body films before putting any screws. And then on the right side are 3-month post-op films. So you can see, even before putting any screws, pretty significant correction of lordosis, kind of straightening out the end plates. And you can see there's a little bit of rotational variance between the cages, which I'll just say that, if you look in her pre-op AP image, there is some rotational component to her scoli. So that's why I think, you get to see that little bit of variation in levels. We could obviously get perfect lateral images if we rotated the patient, but that's it. Thank you. So I think we'll take a moment to entertain any questions there might be out there or that have been coming in through the chat. And then after that, I think Dr. Carson is up next.
Yeah, one thing I failed to mention, if you have any of the attendees have any questions, please feel free to use the chat function, and I will be sending it to the appropriate faculty, or we'll be responding through chat as well. Any simple questions that you guys may have. So feel free to use the chat function for all questions. With that, Dr. Carson, you're up. Thank you.
All right. Thank you. And thanks, Dr. Renaud. You did a great job of sort of bringing us to the purpose of why we're here, which is the small portal access system. So you can go on to the next page. I'm Dr. Carson. I have started using doing a lateral approach via tubular retractor. And so I'm going to discuss that today. My background is I'm a neurosurgeon. I trained in minimally invasive spine surgery with Dr. Foley in Memphis. Did a lot of tubular work, obviously there. Tubular TLIF approaches of a majority. And so when Amplify came into my use and practice, I first started with the dualX cage. And as I started using that and became familiar with it and saw the benefits of it, I started adopting the lateral cage. And sort of a natural progression towards using the tube for a lateral approach is that, you know, I can basically do a lateral through an 18mm tube, and it has a lot of benefits, at least to me and in my experience, as opposed to a 3-blade retractor, which I had traditionally used for my lateral approaches before. So I'm just going to discuss, you know, a case and kind of go through my approach using the tubular retractors. Next page. It's just my disclosures. I'm a consultant for Amplify and have financial interest in the company. You can go to the next page. So, you know, the benefits, at least, you know, in my opinion, to using a tubular retractor as opposed to a 3-blade retractor or 2-blade retractor, you know, one is it's very rigid. There's not a lot of joints involved. You know, when you're attaching a retractor arm to a 3-blade retractor, you have, you know, a few joints in the retractor arm, a joint where it's connecting to the retractor, joints where the blades are fitting into the each of the 3 arms, and joints where those arms open up. So there's little variances in how rigid it can be. With the tubular retractor, it's, you know, a solid tube, and it's quite rigid. The other benefit is that it's radiolucent and good visualization on a lateral shot, fluoroscopy shot when you're looking down the tube. You don't have a lot of the moving parts of a 3-blade retractor that block the view. And then also to that fact that it's a tube is a solid structure, single structure. So you know, you don't get that creep of fat or muscle through the sides of the retractor if the blades are open. I don't. When I used the 3-blade retractor in the past, I never docked it or used shims or anything like that. So for me, this is easily maneuverable. If I want to change the trajectory slightly, then a tube is very easy to do that with. And it's also something that's familiar to me, having used it quite a lot for posterior approaches. So if you're not used to working through a tube, then it may not be as beneficial to you, but for me, it's very familiar. Next page. So I'm just going to kind of walk through mostly pictures of the setup and the case that I'm presenting. So next. So this is a 66-year-old female, came to see me in my office, symptoms of neurogenic claudication. She had a coronal deformity, obviously spondylolisthesis at 4.5, some degree of spondylolisthesis at 3.4 as well, with modic changes throughout. All right, next slide. So this is initial setup. This is a 3-level case that I did, and for the first level, which you can see in place there, we use the 3-blade retractor to sort of start off with, being that it was the first time that I was using the tubes doing this approach. And so with the 3-blade retractor, we didn't have any issues. I didn't need to open the retractor blades. So for the next level, we went with and attempted with the tubes. So similarly, as you would do in any lateral case, I usually go direct lateral unless I'm getting you know, low EMG triggers. Then I might, you know, move more anterior and try to sort of sweep muscle back. but docking the tube, same dilators, and then an 18 millimeter tube just fits right over the standard EMG stimulator dilators that I use. Next slide. So this is a picture with the dilators in place, the tubular retractor placed over them, and then just hooking up the retractor arm at this point. All right, next slide. And this is a picture with the tube in place. You can see this is the initial K wires in place there. Go ahead, next slide. And so for me, I use the microscope. You know, I know a lot of guys don't use a scope, especially if you're doing it through a 3-blade that you can open wide and see. I use the microscope. It gives me good visualization. You can see there on the right the disc space. I can easily see where I'm working. You know, inevitably there's always a little bit of muscle tissue over the lateral border of the spine when you're down there. So I'll do direct stimulation of that muscle, and then assuming everything is free of any neural structures, then coagulate with the bipolar and clear that tissue off. And the microscope lets me sort of visually inspect for any sensory fibers that you might not see or might not get with the EMG trigger. So that is another sort of thing that I typically do just to make myself feel comfortable with that there's no nerves there. All right, next slide. So this is a picture of, and this is that proprietary instrument that Dr. Renaud was talking about. You could see we're looking down the tubular dilator. The large black circle that you see there is actually the handle, but if you decided to remove the handle, you can easily see down here. You could see that this expands wider than the tube, so it fits down the 18 millimeter tube nicely, and then once you're in the disc space, at this point the disc prep has been done, but you can place it into the disc space and expand it at that point to release the contralateral annulus, and also clear any additional loose tissue that you might not have cleared out with the initial discectomy. Next slide. And so this is a picture of the implant going down the tube. Now you can see that the width of the implant's about 13 millimeters going in, so it fits easily down the 18 millimeter tube without any struggle. Next slide. And then this is, you can see the implant fully expanded. I don't have a shot of the tube in place on the lateral, but you can see the tube on the AP shot there, and the cage fully expanded at that point. Next slide. And so this is the pre and post-op images of the patient with the 3 cages in place. Next slide. And again, the post-op lateral shot. And next slide. All right, I think that's pretty much it. So, for me, there's a lot of benefits to being able to use this expandable cage, and the patient has less of a chance, as Dr. Renaud discussed, with the neuropraxia when we're not expanding or using a large opening. So this tube is great for small portal access, keeps all of the fat creep and muscle creep out, and it's been working really great for me. Thank you. Any questions, I'd be happy to answer.
Tyler, could I ask you a question?
Yeah,
Would you
absolutely.
consider if you had a tubular system, and maybe yours has this, but if it had lights that went down it, would you consider doing it without a microscope, or you really like the magnification?
I'm so used to doing it with the microscope now. I do have the lights for the tube. I just never use them. So for me, it's more comfortable too. You know, I'm not bending, leaning over, looking down. I'm my, you know, just have my neck in a more neutral position. So it's a little bit of ease of operation for me too.
Yeah, I think for surgeon ergonomics, I think more people are leaning towards some sort of exoscope or microscope, for either, any type of approach, so to prevent issues with the neck and things like that. So I think for surgeon, you know, viability and not having any neck issues, I think people are looking more at different ways of visualization on other monitors or things like that that prevent you from, avoid the need to bend your neck or crank your neck and things like that. But
Yeah,
that'll,
definitely.
that'll be more common.
Some of these new like heads up, you know, cameras, micro cameras,
Mhm.
um,
Yeah.
might be great for this.
Great. With that, let me turn it over to Dr. Hussain.
And wonderful. So yeah, just as a segue, just to kind of reiterate just one point that I have been using a small camera that goes onto my tubular retractor and have been getting great visualization with that. So I think it's definitely an option in your patients. But I'll be going over just some cases. I know we had the introduction technique, and then we had kind of an expansion of the principles and the technique. I wanted to go over some cases just to show everyone what kind of some imaging looks like and what kind of post-op MRIs and post-op X-rays and radiographs, and kind of show what kind of deformity reduction and things like that we can get with the dualX technology for lateral. So we'll be just talking about some lateral access pearls and then minimally invasive lateral fusion. Next slide. Again, I'm Namath Hussain. I'm a professor at Loma University. I did my residency and fellowship training at Penn State and at Swedish, and so always have had a love for lateral surgery just due to the significant ability to get a large footprint, great arthrodesis, great ability for deformity reduction, and direct decompression, and all the positives that come with that. I'm a big proponent of talking about the potential negatives of direct decompression. And there's a lot of complications with that, and also a lot of issues with that can lead to issues later on. And so I think indirect decompression and deformity reduction is the future of spine surgery. And I think the dualX technology melds well with that. Next slide. Next slide. So just general principles of percutaneous fusion, minimally invasive lateral interbody fusion, less tissue disruption, decreased rates of adjacent segment disease due to the conservation of ligamentous structures and tissue, posterior tension band, less post-op atrophy of the erector spinae musculature. You'll see these MRIs of patients who've had surgery, either open surgery or other procedures, and you'll see a ton of postoperative atrophy of the erector spinae musculature, and this has been more and more studied in recent years. I think that's a huge reason why patients have post-op, failed back surgery syndrome, and a huge reason why patients have to resort to other therapies like spinal cord stimulation and things like that. So I think to avoid all that is better for the patient and better for patient longevity and activity longevity. Patients definitely have a lot of less post-op pain, decreased need for post-op narcotics. I think the literature is coming out with more and more information regarding narcotic use in patients who had open procedures, comparing it to MIS procedures and showing that there's a significant difference, decreased hospital length of stay. Hospital length of stay and wound complications are going to definitely be issues that it's been talked about for surgeons in the past, carrot in the stick, and are they going to actually enforce these in the hospital and the administration. But now recently, there's also, tie-ins with Medicare reimbursement and things like that regarding length of stay and complication rates. And if you can do anything to prevent that or reduce those rates, it's paramount. That is great for the patient, but also it's good for the surgeon in terms of helping with income streams, and also helping with partnering with the hospital to get programs or instrumentation that you need by saving the hospital money. And so those are all good things for the hospital and the institution, for patients, and also for the surgeon. Next slide. So if you can kind of focus your career on those principles, I think it's a great way to kind of set a stage for an excellent career in spine surgery. My focus will be a little bit on a deformity reduction and scoliosis. Just as a brief review, scoliosis can be idiopathic or congenital. It can be adult degenerative as well. And I think these X-rays that I'll show you, what the radiographs show you, how the dualX technology is able to fix a deformity which is a three-dimensional deviation of the spinal axis, and how one or two interbodies in a lateral approach with release of ligamentous structures, annulus, and things like that, and deformity reduction is able to really correct the three-dimensional deviation. And you'll see the radiographs to prove that. Next slide. Again, degeneration in the elderly, scoliosis, spondylolisthesis, multiple comorbidities. So you want to be able to tailor your approach in a less invasive fashion to get them in and out of the hospital quickly, to treat that back and leg pain, and to improve quality of life. Next slide. There's been multiple articles kind of looking at this concept of minimally invasive approaches for interbody fusion, stabilization with screws. Again, there's been kind of controversy regarding a limited correction of a deformity in middle-aged and elderly patients versus a full deformity reduction. And it's a lot of literature is showing that a limited decompression through an MIS approach is more effective in terms of long-term durable improvement in their VAS and ODS scores rather than an open approach. Next slide. And again, frequency of complications, again, with the open procedure, definitely much higher, 15-fold higher than a focused minimally invasive approach. And I think that's what the dualX technology is all about, is about minimally invasive approach with a small surgical footprint. And again, you can get a 15-fold reduced rate of complications and a significantly improved lumbar lordosis and improvement of your PI-LL mismatch. Next slide. Another slide showing basically MIS fusions, again, reduced rate of revision surgery, down from close to 75% with these minimally invasive approaches, and that MIS lateral approaches can significantly increase your segmental lordosis compared to a posterior decompression fusion, which is kind of like the workhorse in the past for neurosurgeons. MIS TLIF, I think, is a great surgery. However, if you're really kind of looking for that improvement in lumbar lordosis or segmental lordosis, I think lateral is the way to go. Next slide. So I've conducted a study here at Loma looking at minimally invasive approaches in middle-aged and elderly patients with adult degenerative deformity. How do we improve their outcomes and reduce complications? Next slide. So we've been looking at patient-recorded outcomes, deformity reduction, blood loss, length of stay, complications. Next slide. And I'm just going to show some cases in this study kind of illustrating the power of dualX and lateral interbody and what kind of deformity reduction that you can get. This is a 73-year-old male with neurogenic claudication, debilitating back pain, had a previous fusion about 15 years prior, had done well with that initial surgery, but then had progressed with his deformity. Here he's got a posterior instrumented fusion with interbodies from L4 to S1. You can see he's got significant adjacent segment breakdown with lateral listhesis, rotational deformity at the level above and 2 levels above, causing severe foraminal stenosis, neurogenic claudication, back pain. You can see how on his upright films, how he's just got horrible SVA. He is just standing forward all the time, constantly activating those erector spinous muscles, constant debilitating back pain. You can imagine how it can be very painful to be in that situation all day when you're walking around. Next slide. And so we elected to do a lateral inner body, and you can see on the post-op MRI on the right with the improvement in the central canal and foraminal stenosis, definitely with that lateral decompression, indirect decompression. And you can see on the X-ray in the middle, the upright films showing the inner bodies graphs, and on the AP showing how the spine coronal deformity is corrected as well. And so I think this is a very powerful method to indirectly decompress the spine, preventing any type of risk of spinal fluid leak or hematoma collection in patients, and able to kind of give them a good postoperative result. And so this patient did really, really well, and was able to go home just a few days after surgery and got a great result. Next slide. This is a 69-year-old male with lumbar radiculopathy, had not had spine surgery in the past, showing severe L3-4 stenosis, some L4-5 stenosis as well, clumping of nerve roots you see in that area. You can see the axial view at L3-4 very tight. You can see the psoas musculature. You can see it. It's a good candidate for lateral inner body fusion. As you're kind of adopting this lateral in your practice in general, and also expandable lateral, I think just as an advice is to kind of start with L3-4, start with the kind of the more chip shot levels first. As you kind of get more facile with lateral approaches, I think you can kind of expand your armamentarium to L4-5. L4-5 is definitely when you're kind of under the gun a little bit with respect to time. You want to reduce psoas retraction, reduce time with the retractor open. And I think that's what speaks volumes in terms of a minimal access portable, because the fact that you either don't dilate at all, don't dilate or open the retractor at all, or minimally open it. And that speaks to the utility in terms of the expandable lateral, the fact that you don't have to open the retractor much. And while you're placing the inner body, you're able to expand the inner body past the margins of the retractor, which I'll show you in a couple of slides. So you're able to access, get a bigger graft into the inner body space, 22 millimeter, without using a 22 millimeter portal. So I think that speaks volumes as to the utility of the technology. Next slide. And so this patient, we did percutaneous fixation with a lateral approach for the inner body implant. And as you can see on the radiographs there, the intraoperative views on the left, and then post-op views standing on the right and the middle, showing that we've got a good deformity reduction, excellent indirect decompression of the foramen over there. Next slide. This is a case of a patient. It's a 70-year-old female with lumbar radiculopathy. This patient has stenosis at the L2-3 level, degeneration of that disc level, some listhesis as well, severe central canal stenosis. Next slide. So this is some intraoperative views showing the percutaneous fixation, and that docking on the left side with the shim after the K-wire was placed, and then disc space prep in the image on the right. Next slide. This is the trialing again on the left side. Again, the proprietary trials which expand. So they enter with a smaller footprint and they expand to 22 millimeters. So you're able to still maintain that small working portal to minimize tissue disruption, tissue retraction. Next slide. And this is that image of that expanded inner body after it's been expanded in AP and cranial caudal direction. And that you can see the foraminal reduction that we get is excellent. So we got a good result there. Next slide. And these are some standing films 3 months post-op, and the patient continues to do well. Next slide. This is another patient, a 55-year-old male with lumbar radiculopathy, neurogenic claudication, back pain. You can see the on the picture on the right, the images of his central kind of cut sagittal MRI, showing that the central canal was well decompressed with his previous surgery. But you can see severe foraminal stenosis still, and also severe adjacent segment disease at the L3-4 level there, causing severe nerve compression. Next slide. So he had a lot of instrumentation. So this was not done by me. This was done a long time ago. So he had multiple inner bodies, multiple cross connectors. So a lot of metal in his body. So he had a little bit of a lateral aesthesis as well. So again, we are able to approach this, from a lateral approach, really if you compare if you look at the image on the left, you can see how the normal disc level he's got above that, and then the disc level adjacent to the screws, how collapsed it is, how completely collapsed that foramen is. And so, again, this speaks to the improvement or the potential that we can get from a lateral decompression, indirect decompression. And so that image on the right is the implantation of the lateral retractor. Next slide. You can see the shim placed after the KO wire was in position. And then you got a little bit of indirect decompression with the shim in that location. Next slide. And then you can see initial annulotomy and minimal opening of the retractor to provide the approach that we need for that small reduced size trial, and then expansion in the disc space. Next slide. Continue disc prep work and the expandable inner body on the right side. Next slide. And then you can see, you can go back one slide. No, I'm sorry, back one slide. You can see kind of memorize in your head the location of that vertebral body above the instrumentation and below. And you can see progressively how there's an indirect separation of those two bones and how you can get that indirect decompression. Next slide. And you can see how, if you compared that in your head, that slide that we looked at compared to now, you can see how that significant reduction of that deformity and that separation of those vertebral bodies to get that indirect decompression and height restoration with the dualX cage in position there. And you can see that small working portal there maintained, and that approach really works well. We were able to obviate all that instrumentation below getting into that mess. Next slide. This shows the allograft implantation. You can see that small whistle that goes in, and it goes in above and below the cage on the image on the left side to implant a bunch of bone grafts. So I pre-fill bone graft, implant the cage, then post-fill, post-pack bone graft. So get a ton of bone graft into that inner body cage to get a great fusion. Next slide. And this is the lateral plate that I put on. And so basically, able to kind of improve that lateral aesthesis, improve that disc space height loss through a minimal portal, getting a great fixation with the cage and a lateral plate, avoiding getting into all that mess posteriorly of the cross connectors, multiple screws, rods, all that kind of older implant technology, avoiding all that and using our newer technology to really help that adjacent segment disease through a completely separate access portal, avoiding all that scar tissue, risk of CSF leak, everything. So I think it's a great technology that's really underutilized, and I think it's going to be really quite helpful for patients in the future as we continue to evolve the technology and get more and more people into lateral. Next slide. And this is my last case. This is a 53-year-old male with lumbar radiculopathy, neurogenic claudication, back pain. You can see multi-level, more so at 3, 4, 4, 5, severe foraminal stenosis, degenerative disc disease. Next slide. So also had a spondylolisthesis. So we were able to neuromonitor, get our K-wire in, get our retractor into position. Next slide. So again, we used a small working portal, did not expand at all. Disc space prep there, and are able to get it our interbody implants. Next slide. And great deformity reduction. And then you can see here percutaneous fixation after that. Great disc space height reduction. You can see that frame in there at the level of the implant. Compare that to the frame and above. It's almost the exact same size. So the amount of deformity reduction is quite impressive. Next slide. And you can see here, foramen are much more open on the post-op MRI. Next slide. And so take-home messages are basically focused minimally invasive surgical techniques can effectively treat older patients with debilitating scoliosis, improving outcomes, reducing surgical morbidity. Key is identifying their symptoms and using the right technology. Next slide. Again, images that you've seen before, the dualX technology, TLIF, T-PLIF cages, the lateral cages there, goes in 13 millimeters, expands in an AP direction to 22 millimeters. So you can great deformity reduction, great results. Next slide. Take home points, MIS spine surgery is here to stay. I think all the benefits with respect to patient care, with respect to, multiple stakeholders, including the hospital, insurance companies, they're going to be focusing on looking at how are you going to get the patient result by reducing costs, having to reduce length of stay, reduce instrumentation, or reduce kind of need for other augmenting technologies to help with fusion like BMP. How are you going to reduce all that cost? And it's going to be with a minimally invasive method that gives you an excellent indirect decompression and also avoids the possible complications of direct decompression. So again, when you're getting out in practice, keep your complication rates low. Patients will come, admin will love you, learn the nuances while in training and then during your first few years of practice. And so I think the best way is to kind of continue to evolve the technique, attend courses, listen to webinars, go to surgeon one-on-one courses. Again, at Loma Linda here, we're always available to do that with anyone. So again, continue to drive the field forward and provide data, and hopefully we'll continue to provide evidence for payers, patients, surgeons, everyone to kind of adopt this new technique. Next slide. I think that's it. Thank you.
Dr. Hussain, I'd like to make 2 comments and ask you a quick question. One comment is I had to chuckle that you said the hospital administrators love you, because I don't think I've ever heard anybody say that about the surgeons. So good for you. That's great. Secondly, I think that second to last case you showed with adjacent level to prior fusion stuff, especially anything above like L4, I think laterals are just such a key to treating those without having to get into all the old hardware and, like you said, all that stuff. Those are just ideal
It's such
cases.
a game-changing technology. I mean, the morbidity of going into that mess with that patient would have been horrendous, and this is just a minimal access approach to really just focus on that level and the amount of morbidity that you're avoiding, that is just where lateral shines with like no other, you know. For everything else, yes, lateral is great and it can work well, but for those select patients, it's just like a no-brainer, absolutely no-brainer to go lateral.
Yeah, I agree. And then my last question was that maybe I missed it, but it appeared in a lot of your earlier cases that you had screws in and were doing the lateral. Are you doing those all prone, or are you doing some lateral position screws, or what's your take on those kind of advanced techniques?
A combination. I think prone lateral is a great technology that I've really incorporated into my practice recently, and I think it helps a lot with workflow. So I think it helps quite a bit. So again, I think lateral screws in the lateral position are also doable, but I think the field is moving slowly towards prone lateral, and I am too. I think with the increased amount of lumbar lordosis that you get, and also when the patient's in a prone position with the thighs extended, I think you get the lumbar plexus does move back a little bit, and I think the EMG numbers that I get during monitoring at L4-5 are much better in a prone position at L4-5 than in a lateral position.
Great. Yeah, so I think that's interesting, and it kind of harkens back to my comment earlier. Like, if you're doing lateral, this particular implant is an easy fit, right? Regardless of if you're doing it prone, if you're doing it lateral, you know, however you want to do it, ATP, whatever, that you don't really have to change your practice too much. This might just allow you to make that next step to being even more MIS, you know? So
yeah, that's spot on. That makes, yeah, exactly. It's a surgical adjunct. You're not changing your practice. You're just using the power of technology to make your footprint, your surgical footprint smaller and improve patient outcomes and get the surgery done faster.
yeah, I agree. I think I could be wrong. Maybe Andy will correct me, but at least for the last 4 or 5 years, this is the only implant on the market that I think expands anterior to posterior and then vertical in the lateral sector anyway. So really a unique product. Yeah. So Andy, any questions from the rest of the viewership, or any comments on your side from a business perspective or development futures?
No questions. I think we were all intently impressed with the cases, and certainly I was very focused on looking at all the different. I think I was present in a few of those cases, and to be able to see a lot of the post-op images, several months out, a couple of them maybe a year or two out, post-op X-rays, it was quite significant for me personally. So thank you for sharing all of that. Once again, thank you to our faculty for preparing for this and really putting a lot of work into it, and also being one of the forefront runners in adopting this very novel way of doing it. And in hindsight, being able to really tell a really good story about how this helped patients ultimately. And I think with other technologies and other similar sort of technologies kind of coming into a similar field, I think that also legitimizes and kind of validates the value of this approach as well. So all in all, I'm very happy about obviously today, and of course the work that the 3 surgeons today have done for this technology so far, but also how this technology and this sort of approach is really becoming more of a standard that is helping with patients and so forth. That's coming into play. So very happy about that. For those who've attended, thank you for the time again. We will be sending out emails to all the registrants with the link to the recording. So we recorded this session. So if anyone wanted to go back and look at it, this will be available on our website. At least a link to the video will be available on our website. And we have a YouTube channel that houses all of the past webinars such as this as well. So, and then lastly, if you have any questions whatsoever, info@amplifysurgical.com, obviously around this technology, how this can be brought to your hospital or to your practice, please email us at info@amplifysurgical.com. And also, there's a contacts page on our website that you can go to for any questions at all. So with that, if there's nothing else, thank you very much. Good evening and have a good night.